And we've got a quorum in the meeting, so we can start. I'm just struggling a bit here with my video. Okay. Good morning, TM and the department and all members present. We can start the meeting. The agenda is in front of us. I will read through the agenda. It is the opening and welcome by the chairperson. Then we will deal with apologies. And the business of today is the informal provisional briefing by the Department of Health and the Health Insurance Bill, Section 76. And then we will have discussions and responses up until 12 o'clock. After 12, we will do our official business, the adoption of committee meetings, and also the budget vote reports and any other business. Can I get a mover for the adoption of the agenda?
Dongeni, good morning.
Good morning, Member Dongeni. Thank you. Is there a seconder for the adoption of the agenda?
Member Lutuli.
Thank you, Member Lutuli. Members, allow me to welcome the minister with my video because the background is not loading. At any rate, let's continue. Let me take the opportunity, members, to welcome the Deputy Minister of Health and his team in this very, very informal and important briefing on the NHI bill. All of us know in this meeting that we were looking forward to getting this presentation, and that all of us is looking forward, DM, to briefing from you and your department, as we all are very excited that finally we will get the opportunity as the select committee to get the insight on this bill, which will take health in this country on another level, TM. We are very, very excited. I also need to welcome the State Law Advisor, Mr. T. and the Legal Advisor from Parliament, Ms. Sue Ann Isaacs, who has also been invited to this meeting. I would also like to inform this committee that we did receive an apology from the Minister of Health, Dr. Zopasla, because he will not be able to attend this briefing. But we are very fortunate to have the Deputy Minister, Dr. Blomo, with us. And it is really, Dr. Blomo, a very good and exciting day this morning for our committee. So welcome to everybody. I already apologize on behalf of the minister, and then we also do have another apology from Honorable Member Nkosi, who is representing us at the 52nd CPA Regional Conference in Sierra Leone. But aside from that, apologies, I hope, and I know every other member on the platform. So then, without any further ado, can I ask the members to accept the apologies from the minister and from Member Nkosi? Thank you. I will wait for the members. Can we have somebody move for the adoption of the apologies?
Dongeni.
Thank you, Member Dongeni. Is there any other seconder?
Chabeling.
Thank you, Member Chabeling. DM, the floor is yours. We are excited to hear from you this morning, DM.
Okay. Thank you very much, Chairperson, and thank you very much to all the honorable members in the Select Committee in the NCOP. We welcome this very much as a department. I also would like to thank you for accepting the apology of our minister because of other heavy pressing commitments. Let me start by saying in our medium-term strategic framework of 2019-2024 and in our annual performance plans, we have National Health Insurance Bill as our priority. We would like to thank the Chairperson and honorable members for inviting us to share with the honorable members what the bill seeks to achieve, of course, in this informal provisional briefing. As we probably know, the bill is still in the National Assembly. The strategic objective of the Department of Health is to achieve a universal health coverage through the phased-in implementation of the NHI. It is a policy shift that seeks to ensure that all citizens and residents, irrespective of their socioeconomic status, have access to good quality health services provided by both public and private sectors. It seeks to bring about protection against financial risk when someone accesses health services. It looks at health as a public good. The government aims to reorganize the health system and introduce several structural reforms through this NHI. Of course, Chairperson, as you have alluded, this bill was tabled in the National Assembly in August 2019 by the Minister and then referred to the Portfolio Committee. The Portfolio Committee then undertook to convene public hearings on the bill in all 9 provinces, at least 4 hearings per province. As a department, we attended almost all of those hearings, but not all of us, some of us were there consistently. The bill is currently as with the Portfolio Committee and still is actually being processed. And if you go according to last week's processing of the bill by the Portfolio Committee, it probably needs another 1 more month, and probably they'll be ready to then bring it to the House, which in that regard, therefore, it will then see its way coming into this House. We therefore welcome honorable members that you are, even prior to getting it formally, you have asked us to come and share with you what is in the bill. May I therefore, Chair, with your permission, invite our Director General, Dr. Buthelezi, who is also logged in, to then take us through the formal presentation, or delegate if he has other members. There are some other senior managers who are logged into this meeting who probably will take it forward. Thank you very much, Chairperson.
Thank you very much, Honorable Deputy Minister. Special greetings to the Honorable Chairperson and members of the Select Committee. As my principal has done the introduction, firstly, I would like to indicate that I am joined by Dr. Nicholas Crisp, who's the Deputy Director General for NHI. He's the one who is going to lead us through the presentation. Then we've got Dr. Aquina Tulare, who supports him as a health economic specialist. And we also have our parliamentary liaison officer with us. So with the indulgence of the chair, so that we get into the business of the day, I would like to invite Dr. Nicholas Crisp to lead us through. Thank you very much, Honorable Chair.
Good morning, honorable members of the Select Committee. Good morning, DM. Morning, DG, colleagues on the call and others. It's a pleasure to be here. And thank you very much for that very warm and exciting welcome. It's so nice to be enthusiastic about national health insurance, because we are. I'm going to go directly to screen sharing on my side so that we can present a formal presentation. So if you can just indicate, please, if you can see the presentation. Is it visible? So can you see?
Yes, we see.
And I'm audible. Okay, thank you very much. Okay, so thanks very much. What I'm going to do is just take you through the contents of what's in the bill without going too much into explanations, because we saw on the agenda there's going to be discussions, and it's probably easier for members to note points that they wish to raise with us afterwards. So at this stage, what we're going to do is just go through the contents of what is in the bill. So we'll start with it starts with the purpose, and as the Honourable Deputy Minister has said, what we are aiming to do is to establish a fund which is the legally defined organ of state, and what it does in the bill is establish this fund with its functions, its powers and duties, and the controlling and governance mechanisms by a board. So it outlines the composition of the board, the appointment of members of the board, who's the chair and vice chair, how the meetings of the board will be formalized, and the appointment of committees of the board, and the usual things that one does about who would be disqualified from membership of the board. The second thing that it does is it aims to define the beneficiary. So who will benefit from the services that the fund is going to pay for, and it provides for who's going to deliver the services to them. And we will talk a bit more about accredited providers of personal health services. So the criteria for the accreditation and reimbursement of those providers needs to be explained in law, and it's also contained, you'll see just now, in this bill. It provides for the minister to determine the healthcare benefits, but also describes committees that will advise the minister on that over and above what happens at the administrative level within the fund administration. So there are 11 parts to the bill. We'll go through them each one just to show what is in them. I've already explained the purpose and application of the Act. But briefly, what it says is that we will establish the fund through which mandatory prepayment will be made so that we can achieve sustainable, affordable, universal, and that's a critical word, access to quality health services, quality being the imperative of where we are aiming for. So what the structure of the bill does is it creates a model which we call a single purchaser, single payer model. And it does that by pooling the funds. So taking all the existing resources and putting them into one single fund so that that fund can do the purchasing of healthcare in a strategic manner. So we speak of strategic purchasing of healthcare services, and then also the goods that are provided or the products that are required to deliver those health services. And it strategically purchases from accredited and contracted healthcare providers. So that's the purpose of this bill when it becomes an act. So the application of the Act, it will apply to all health establishments in the whole country except the Military Health Services and the State Security Agency. The military have their own health services which are outside of the rest of the public space. The Act does not affect the funding and functioning of any organs of state in respect of healthcare services until the relevant legislation has been enacted or amended. So at this stage, we are in that period of refinement of the contents of the bill. And where there is conflict with any other legislation, this Act will prevail, except for the Constitution and the PFMA. That's important because there are many other pieces of legislation, including the National Health Act, and if there's an interpretation of which one is the lead legislation, this will be the lead legislation. So the second part of the bill deals with access to healthcare services, and it speaks of population coverage and it speaks of registration of users. So in terms of population coverage, the fund will purchase services on behalf of South Africans and on behalf of permanent residents, refugees, and whether they are inmates or any other specific categories of foreign nationals that's covered in the bill. There's a clause that deals with asylum seekers and illegal migrants. And what it does is it limits the extent to which they get care to basic health services for children, but also emergencies and notifiable conditions. And then it covers the fact that we get a lot of tourists and people coming on business. So with those foreign nationals, they are required in this bill to have travel insurance when if they access healthcare services and in South Africa. Now, the bill uses the word user, so it's anybody who uses any part of the health system. And you will see as we go through the bill, it doesn't matter whether you're a private or a public provider. The user will have access to those services, and those users are described as eligible persons. So in the population coverage, whoever's eligible must then register, and that includes children. And the users must register with the accredited healthcare provider or establishment. So that's clinics, GP doctors, or other primary healthcare providers in the communities where they live. Newborns will be automatically registered on their birth registration. And then the supervising adult must make sure that they register children where there are child-headed households. The bill also provides that we will use biometrics and other forms to access prescribed information so that we know who the users are and make sure that we don't mix up treatment and people get what they are entitled to. So what are they entitled to? The bill says that the users of healthcare services will have the following rights: the quality of health services free at the point of care. And that's one of the fundamental tenets of what we are trying to achieve with national health insurance, that people do not pay for healthcare at the point of care. The user is also entitled to information relating to the fund, relating to the service benefits that they're entitled to, and personal information. No person may be refused access to healthcare on any unreasonable grounds, and the access to healthcare must be provided within a reasonable time frame. The individuals will also have reasonable decisions about their own healthcare or access to those decisions and be able to engage with healthcare providers. There's a provision that users may complain if they're not happy with the service they're getting, and there's a process by which that will happen. And any decision that is taken by the fund, for instance, to deny any particular care for any reason, must be given in writing. Users will also be allowed to purchase healthcare services that are not covered through the fund. We'll come to this again a little bit later, but essentially the fund will strive to purchase all the healthcare that is essential to all of us and to society. But because of the nature of medical science and health sciences, there are sometimes services which are not deemed essential or that are financially beyond our reach. And then individuals in society will be allowed to have complementary voluntary medical insurance to cover such care. So as far as healthcare coverage is concerned, the fund must purchase the services on behalf of the beneficiaries. And that's a critical tenet of the national health insurance. We don't want that individuals are required to purchase their healthcare at the point of care, that the fund must purchase the healthcare. Where the provider or the establishment is unable to provide that care, then the provider must transfer that user to another provider or establishment that does have the capacity to deliver the care required. Now, in order to get efficiency in the system and to make sure that people don't wait inordinately long and the system works smoothly, the user must enter the system at primary healthcare level, and then the primary healthcare will direct them, and they must follow the referral pathways as a condition of their entitlement. In that process, the minister must designate central hospitals. That's the pinnacle care at which the most complex services are provided. And the bill says that we would like those central hospitals to be semi-autonomous, which means that they will have their own managerial integrity, although they are still part of the government as components of government. So we're not trying to privatize them, we're trying to give them more autonomy in their management in this bill. Treatment will not be funded if there's no medical necessity or if it's not cost effective. And if the treatment requires medicines or other products that are not on the formulary, then those medicines will not be part of the treatment. This is a normal practice around the world, and there are it's provided for in this bill how we will treat it within the national health insurance. If the fund does decline a benefit, the fund must give reasons and allow an appeal process. so that it's individually considered. The key point is that cost to the patient must be zero at the point of care, so that we do not limit people's rights of access because they are unable to afford it. So let's move to Chapter 3 of the bill, or Section 3 of the bill, that deals with the establishments of the fund. Now, we have a particular set of provisions in our law, of which the Public Finance Management Act provides for public entities, and there are a range of different public entities provided for. Our bill, this NHI bill, says that the fund will be a Section 3A public entity. It's actually Schedule 3A public entity, which is a schedule of the Public Finance Management Act, where the A part is national entities, and the Schedule 3 entities do not trade or do business. They are just there to facilitate the business of government. So in this Schedule 3A public entity, the functions of the fund, of the entity, will be to actively purchase services and to enter into procurement contracts for goods. Those goods that we refer to are medicines, diagnostics, devices, and other consumables that are required to provide the services. The function must be to ensure that there's timely reimbursement to the providers of healthcare. The fund will determine the payment rates annually, and there will be a prescribed manner in which that happens. Obviously, all laws need to be expanded on in regulations, so the prescribed manner will be in the regulations. The bill must appropriate funding for healthcare services at various levels, so make sure that there's proper distribution of the resources available, and is responsible for monitoring the quality and the standard of the healthcare services provided by the accredited providers. The performance profile of all service providers will be monitored by the fund, and there's a provision in the bill that providers will be paid for performance, so that we encourage the increasing improvements in quality across the whole service. The fund must monitor the impact on the fund on addressing healthcare needs. So not just distribute money, but make sure that we are moving towards a more equitable provision of healthcare across the country, and that we're having an impact on the outcomes of the people in the country. The fund must liaise and exchange information between the Department of Health. There are several other entities of the department, and there are several statutory councils, so it must not operate as an island. It must maintain a national database of the population, so that's the demographic or the actual population characteristics, but also of the disease profile or the epidemiological profile, so that the fund is able to see that it is delivering services to, or paying for the services that are delivered to the population. There's a requirement that the fund must perform its functions in the most cost-effective and efficient manner, and the fund must be aligned to the health policies approved by the minister. So it does not remove the responsibility from the Health Act, where the minister and the National Health Council formulate policies. It must implement and align those to those policies. And then the fund is also has a responsibility to contribute to the protection, promotion, improvement, and maintenance of the health of the population generally. So even outside of the delivery of specific services, being involved in the discussions and debates about the impact of other functions within society on health. So turning to the powers of the fund. So the fund, as we said, is an entity with an administration that is responsible for paying providers and doing other things. So in order to do that, it must employ personnel. It must be able to purchase and acquire the necessary goods, equipment, land and buildings, or whatever it's required to do its business. And it may then run the necessary bank accounts, so draw, draft, accept, endorse, discount, sign and issue promissory notes or bills, and other negotiable or transferable instruments. So basically that means it must manage its own money in order to run its own operation. The fund must insure itself against loss, damage, risk or liability, and it must investigate complaints against the fund if anybody lodges such complaints, but also against providers, establishments, or suppliers. The fund will also have powers to implement best practices in terms of its purchasing of services, and obviously then respond to that to be able to improve the efficiencies. That also applies to the procurement of whatever goods are required and the efficient delivery of services, the way in which the data is collected and analyzed, and to ensure that there's a fraud prevention. So just now we'll talk about risk management and fraud prevention. The fund also has powers to undertake research relating to the improvement of universal health coverage and to exchange information with organs of state generally, so other government departments and other entities. There are also powers in the bill given to the fund to institute or defend legal proceedings and to negotiate the lowest possible prices for services and goods. Looking at the board of the fund and the governance arrangements, the bill provides for the establishment of a board which is responsible for governing and oversight of the administration of the fund. And this board is accountable to the minister, as is the case with all Schedule 3A public entities. The bill provides for the constitution and the composition of the board. It's laid out that there are certain expertise which should be present in the board at all times, with a membership of 11 members appointed by the minister, and that those members would each serve a 5-year term, which would be renewable once. And there are exclusions. There are provisions in the bill where people would not be on the board, for instance, where they have a conflict of interest in the activities of the fund. The minister will also appoint, according to the bill, an ad hoc panel to interview the candidates and recommend the shortlisting of the people who should be appointed to the board for the minister's appointment. The bill provides that the minister may remove a board member, but it's not arbitrary. There are specific conditions provided for that, and also that the minister may dissolve the board and then appoint an acting board for up to 3 months. These are quite standard terms in Schedule 3A public entities, so there's nothing particularly different from any other 3A public entity. The chairperson and the deputy chairperson are specified in the bill, the minister to appoint the chair and the board selecting the deputy. So regarding the functions and the powers of the board itself, the Schedule 3A entities, as I said, refers to the Public Finance Management Act. And in that act, it says the board will be, the boards are accounting authorities. So this is repeated in this bill. There's also a provision that the board must meet at least 4 times a year. There's no limit that they should meet only 4 times a year, but no less than 4 times a year. And it's the responsibility of the board to advise the minister on matters relating to the fund, including its financing, administration, and the pricing of the services that the fund is responsible for. The board will define the types of reports required from its executive management to enable the board to report to the minister, and through the minister, obviously, to Parliament. There's a provision in the bill for the conduct and disclosure of interests. This is also a fairly standard requirement in the PFMA, and any paid employment that will conflict with the work of the fund must be disclosed, and the usual declaration of interests has to be disclosed. The bill does not prescribe the procedures by which the board will conduct its business, but it does say that the board must determine its own procedures. The remuneration and reimbursement of the members of the board is, as always in the PFMA, a matter between the responsible minister, so the Minister of Health, with the Minister of Finance. Okay, then the day-to-day running of the organization, the bill provides for a chief executive officer and specifies the technical competence and experience that's required, and that the board would interview the candidates and recommend the candidates to the Minister of Health. And the term of the chief executive officer would be 5 years, renewable once. And the board may recommend the removal of a CEO, obviously if there are that removal. The responsibilities of the chief executive officer is that he or she must account to the board. The functions are designated by the board, and this person in this function is responsible for the administration including the people who run the organization, the human resources, but also the investigative unit responsible for complaints, any fraud or corruption that's reported, and to make sure that risks are identified. And it's the CEO who's responsible for the appointment of staff to the fund. Working towards the services and the delivery of the services that the fund will pay for, the CEO is responsible for the liaison with the district health management officers and is also responsible for establishing the necessary units within the fund for planning, benefits design, benefits pricing, provider rates and payments, accreditation of providers, purchasing of goods and purchasing of health products, contracting, payment administration, performance monitoring, and the identification of risk and management of fraud. It's the CEO who is held accountable for the annual report and must prepare the annual report. And there's a provision in the bill for the CEO to meet with the Minister of Health, the DG, as well as the Office of Health Standards Compliance. And the bill says that should happen at least 4 times a year to ensure that there's continuity of the activities of the fund with the delivery of the services in the country. So Part 6 deals with the committees to be established by the board. The board must govern the organization, and to do that, will need to appoint committees such as a remuneration committee, a finance committee, and so forth, and that those committees should meet 4 times a year. Over and above that, the board may from time to time, or even on a permanent basis, require certain technical committees, and it's up to the board's discretion to establish and disband those committees as they need them, as long as the persons that are participating in these technical committees have the relevant expertise, they are fit and proper persons to fulfill the functions, that they don't have a conflict of interest in the activity of those committees, and that they don't abuse their power. Now, the bill provides for a number of very specific committees. As I said in the beginning, notwithstanding the fact that the fund will employ personnel who are responsible for the day-to-day technical work, the bill provides that there will be advisory committees that review that technical work and provide specialist technical advisory input, and then advise the minister, first the board and then the minister, on various things. The first one is the Benefits Advisory Committee. So when we speak of benefits in the bill, we're talking about the healthcare package or the healthcare benefits, services that we will be entitled to as citizens. So to define whether these benefits will be provided or not, this committee will comprise expertise in medicine, public health, health economics, epidemiology, and the rights of the patients. And the Minister of Health, according to the bill, will appoint the chair of this advisory committee. The advisory committee members will serve a 5-year term, again renewable once, and the service benefits per level of care will need to be outlined and advised upon by this benefits committee. So we're referring to primary health care and various levels of hospital care. And what they are looking for is the cost-effective treatment guidelines and where benefits, where there should be regulations relating to the details and the terms of reference of how the benefits will be structured and made accessible to the public. Now, once a benefit is defined and designed and the economics of the ability of the fund to pay for it, then it needs to be priced. And pricing involves a separate committee so that there's not a conflict of interest. The bill provides for this healthcare benefits pricing committee to recommend prices that will be paid to the providers who deliver these healthcare services. Once again, the minister will appoint the chair. And the bill provides for 16 persons with a very wide range of expertise in actuarial science, medicine, epidemiology, health management, health economics, health financing, but also in labor and the rights of the patients, and for a member to represent the minister. The third committee that's provided for as a statutory committee in the bill is a stakeholder advisory committee, where the intention is to have representatives from those who deliver healthcare and those that receive the healthcare, so professional councils, health entities, labor, civil society organizations, professional associations, and advocacy groups to advise on the stakeholder involvement in what services are provided to whom, where and why and when. In all of these committees, there's a requirement for disclosure of interests so that there's no conflict in decisions that are taken on what advice to provide to the minister. And there's also a provision for the procedures and remuneration, once again in consultation with the Minister of Finance. Okay, so now we'll move to Section 8, where the bill outlines the role of the minister and various other parties. The role of the minister is stated in the bill as the governance and stewardship of the national health system and of the fund. So overall, the Parliament will hold and the law will hold the minister accountable for the stewardship of the health system and the National Health Insurance Fund. The minister must therefore delineate the roles and responsibilities of the fund, the national and provincial departments of health, and must take into consideration the provisions of the Constitution, the National Health Act, and there are other pieces of legislation to prevent duplication and ensure that there's equitable provisioning and financing. And that's what we mean by stewardship, the overall big picture of who does what. That's the role of the minister described in this bill. The role of the national department is described clearly in the National Health Act and is also the outcome of provisions of the Constitution. In the National Health Act and in the provisions of this bill with the amendments to the National Health Act, the role of the National Department is to set guidelines for norms and provide guidelines for norms and standards. It's responsible for overall human resource planning, development, production, and management for the whole health sector, responsible for the coordination of health services throughout the country, planning development of the public and private health establishments, so making sure that they know where everything is and fitted, where they fit into the delivery system, the integration of the health plans of the different role players within the health system, and then subject to Section 57, which deals with transition, the minister may introduce National Health Act amendments to delegate functions to provinces, to designate categories of hospitals and to ensure their autonomy as legal entities, and to establish the district health management officers as components of the government. Also in this part of the bill, it deals with the role of medical schemes, and the intention, as we said right in the beginning, is to create a single pool with a single funding model. But once the national health insurance is fully implemented, the minister will then introduce regulations that limit benefits to services that are not reimbursable by the fund. What that means is that we recognize that always in any health system, there are services or benefits that cannot be provided by the fund, either for economic reasons or because they're not deemed to have an impact on the health of the country. And this provision in the bill allows for medical schemes to provide those, what we call top-up services. There's also a provision for the District Health Management Office. So in the bill, the intention is that the health system will be managed mostly at the district level, and that each of these district offices will be national government components, which must then manage, facilitate, support, and coordinate the provision of the primary healthcare services for both personal health and non-personal healthcare at the district level. So strengthening the authority and the responsibility at district level for getting a little bit closer to the public. For the actual service delivery on the ground, there's a provision for the establishment of contracting units for primary healthcare. Those are, for the honourable members, more like what one would regard a sub-district at the moment. So there'll be a lot of these contracting units. which will be the preferred organizational unit with which the fund will contract for personal health services in the primary healthcare space. This will be an organizational unit built around each one will have a district hospital, but the bulk of the services in the contracting units will be delivered at clinics, community health centers, ward-based outreach teams, and then a range of private providers, specifically general practitioners, pharmacies, and so forth, within that specified demarcated area that will then assist the fund in providing understanding the burden of disease, that's BOD, making sure there are enough accredited public and private providers to deliver the services to address the burden of disease, and then also to manage the contracts with all of those providers and ensure that the referral system through the district hospital is functional, and to integrate the public and the private healthcare service providers. So in other words, the roles of the general practitioners, the role of the private pharmacies and the public service clinics and health centers and so forth. There's a provision for an Office of Health Products Procurement. Now, the intention with this is that one gets a lot of financial gains by having big numbers. So buying in bulk is always cheaper than buying in small amounts. So by understanding the huge volumes of different products, that's medicines, diagnostics, devices, and so forth, by centralizing and facilitating the coordination of procurement, one can get far lower prices, and you can specify and manage the quality of those products more easily. So what the office must do is determine the selection of the products, and that's done through a specific process of evaluating the technology, we called it health technology assessment, and then managing the procurement process, the price negotiations, and contract management. The bill does not describe or prescribe which methods to do these by, because they change over time, and there's quite a lot of international movement on how that works, but it provides for the legal framework for this to take place. There's support for the development and maintenance of what we call a formulary. So the formulary is all the products, essential medicines list, that's the EML, the essential equipments list, and there may be others that come out of the clinical guidelines. And that formulary is the actual products that the fund will pay for in the delivery of the benefits. And then, of course, the review of that formulary is an ongoing process, because burden of disease is changing. There are new medicines and new treatments and options entering the markets all the time, and prices are changing as patents expire and so forth. So this office has a responsibility for making sure that all the health products that are used and paid for by the fund are of a good quality and the most optimal products for the purpose. Now, we need healthcare service providers to deliver the care. That's all the health professionals. And the bill provides for the accreditation of these service providers. The process, and this is all in Section 37, the process by which that will happen is starting with certification from the Office of Health Standards Compliance. So the entry into accreditation with the fund will be a requirement that the basic outline of safety, cleanliness, et cetera, and governance that is prescribed by the Office of Health Standards Compliance is the starting point. But then over and above that, the applicant who wants to be accredited as a provider of the fund must provide a minimum range of services, must have the appropriate number and mix of health professionals to deliver that set of services, or let's call them benefits as well, must undertake to adhere to the treatment protocols and the referral pathways that are provided for in the law, and must submit the necessary information for the fund generally to manage and understand strategic purchasing. And that's the ID, diagnostics, procedure codes, treatment, the length of stay and referral. There's quite a lot of information that providers must provide in order to participate in the fund and be accredited. They must also adhere to the national pricing regimen, and of course then conclude a legally binding contract between the fund and that establishment or provider, that for a maximum of 5 years they will be accredited to provide, and then that's a renewable contract on an ongoing basis, provided they continue to adhere to the provisions for accreditation. And the conditions for renewal will be related to the benefits package, continued certification of quality, the continued provision of the correct staffing mix, etc. Providers can be refused accreditation if they don't comply, and there's a provision in the bill for them to appeal if they have been excluded and not accredited to participate in the fund. All providers must participate in the information platform. It stands to reason because they will not be able to be paid if the fund is not able to see what services they are delivering, when and where and to whom, and because the prices are fixed to those benefits that are being developed, they must be part of the National Health Insurance Fund's information system, and that's how they will get their payment, which is also provided for in this part of the bill. So that takes us to the section that deals with the actual information platform of the fund. The providers and establishments, so when we talk about establishments, that's defined in the National Health Act. That could be a general practice, it could be a pharmacy, it could be a hospital. The providers are the people who are professionals working inside those establishments. They must submit information that will be prescribed, and they will participate in the platform. They don't have to have exactly the same systems installed everywhere. The fund's not going to provide them, but they must be interoperable with the system. And so that will enable the fund to use that information to plan, to budget, to monitor, to make sure that everyone's adhering to the guidelines and doing the right thing to the patients. But the personal information on the system will be confidential and will be protected in terms of the laws that provide for the protection of personal information. But also because we work in a health environment, there are health ethical reasons for protecting and keeping information confidential. The payment of service providers, the bill provides that primary care providers will be contracted and remunerated by the CUPs. You will recall earlier I said that the CUPs, the contracting units for primary healthcare, will be the preferred process through which primary healthcare will be delivered and paid. So the intention, and that's provided for in the bill, is for these primary care providers to be contracted and remunerated via those contracting units. Then there are specialists and hospitals of various levels of sophistication and competence. And all of those hospitals, the payment will be, what's provided for in the bill is for the payment to be performance-based. There's a separate provision for emergency medical services, and it's described in a particular way because the emergency medical services are dealt with differently in the Constitution. They have to be dealt with a little bit differently in the relationship to how they get paid in the fund. And then there's a provision that the minister will make regulations relating to payment mechanisms. Rather than put that in the bill, these are evolving systems around the world. And although there's guidance provided in the bill, it's not rigid. And so it provides in the bill for the minister to make regulations. Now, there's a section that deals with complaints and appeals. There are not a lot of reasons why either providers or the public might be unhappy with the services. And what the bill provides for is that the fund must set up mechanisms to receive complaints, must have an investigating unit that establishes the facts of the complaints and that the complainant is responded to in writing. There's also a provision for the lodging of appeals and a limitation on the time period of 60 days for the receipt of the notification. And the bill provides quite a lot of detail for the establishment of an appeal tribunal, a 5-person appointed tribunal appointed by the Minister of Health, to investigate any appeals and complaints. The powers of that tribunal are similar to those of a high court, and the secretariat will be provided for by the fund. The procedures and remuneration of the officials of the appeal are also provided for specifically in the bill. We're getting towards the end now, and the question is, where does the money come from? So what the bill provides for is a range of sources of funding, which includes the appropriations from Parliament, but it also includes any fines or interest on money that is in the bank for any period of time, receiving of bequests and so forth. But the chief source of income, which is described in the bill, is appropriations. So that means money that is passed by yourselves in Parliament and from general tax revenue. And the intention is to shift the current funding from the provincial equitable share and the conditional grants that come through the current appropriations mechanism into the fund, but also over time, once the systems are in place, to shift the medical scheme tax credits and payroll tax and a surcharge on the payroll tax to put that into the fund directly. So the process that is explained in the bill is obviously when funds are appropriated, they're appropriated to a ministry, and through that ministry then to the, or department of a ministry, and then from there into the various entities, including this one. Because this is a Schedule 3A entity governed by the Public Finance Management Act, the auditing is done by the Auditor General of South Africa, and annual reports are, although the bill provides for annual reports, submissions to Parliament, the Minister, and so forth, these are also requirements in Chapter 6 of the Public Finance Management Act, where there's quite a lot more detail of what is required from public entities by way of reporting to Parliament. Then there are a number of miscellaneous matters that are dealt with within the bill. Although they're miscellaneous, they are still extremely important. The one is around the assignment of duties and delegations of power, so that the board may delegate, the minister may delegate all except regulations powers to the board. The board may delegate certain of its powers to the CEO, and the CEO may hold executives and other officials of the fund to do certain duties and have the delegations to execute those duties. There's a specific provision for the protection of confidential information, notwithstanding other legislation, and the bill refers to the other legislation as well, so that there's not a conflict about it, but it's like double braces. There's a provision for dealing with offences and penalties, and there's a provision for regulations so that the content which we've outlined in the bill can be added to and amended from time to time when the environment changes. There's a provision for various directives that can be given. And then there's a section that deals with transitional arrangements. And what the transitional arrangements are trying to do is to take us from the system that we're in at the moment through a period where we've been now with health system strengthening initiatives, largely driven through conditional grants, formulation of this legislation during this transitional period, and then putting the foundation for the functional fund in place. So the administration to be able to deal with the money, define the benefits, et cetera, that we've been outlining in this presentation. And during this phase 2, also starting to give more power to central hospitals, structuring the contracting units for primary healthcare, putting the mechanisms in place for the accreditation of healthcare providers, and so forth. We've lost some time during COVID on this phase, but quite a lot of the work that is intended for this phase has still been done during COVID in getting us to the end of phase 2. When we move into the next phase, of course, that is then really mobilizing, shifting the funds through appropriations and running the fund in the manner that's been described as I've been going through the bill. This as with any piece of legislation, it impacts on a number of other pieces of legislation. So there's a schedule at the end of this bill, which includes the acts that are listed in this slide, where there are subtle or otherwise changes to wording and intentions that need to be dealt with at the same time as the implementation of this bill to avoid conflicts or misinterpretations. I won't go through each of them, but perhaps the one to pay attention to is the National Health Act, where some of the mechanisms that are described in the NHI bill will be provided for in the National Health Act. So last comment is around what the bill, when enacted, will do to the role of the provinces under national health insurance. So as we said at the outset, the intention of the NHI generally is to establish a universal system. And universal, we're talking about one universe, not 9 provincial universes and not a separate universe for the public and a separate for the private. One universal health system. So what the bill will do when it's enacted and when the changes are made to the National Health Act is that it will centralize the functions nationally to create the universal system. And then it provides for the delegation of the provider functions back to the provinces so that the provinces manage the provision of the healthcare services, but are also responsible for the stewardship of the entire system in the province. So that means the public and the private sectors, provincial, tertiary, provincial, regional, and the emergency services. So still responsible for making sure the coherence of the system, managing the ambulance services, which is how we get patients between the levels of services, providing oversight and assisting the district health management officers to do the work that was described earlier when I went through that section. And there's provision for the delegation of provincial and regional hospitals and the provision of specialized hospital services. Remember, the bill is trying to get more autonomy to the hospitals, but that needs oversight. And that would be a role of the provinces under the National Health Insurance. And then, of course, there's interprovincial and intersectoral coordination. Health is not an island. So the relationship with the police, with the traffic authorities, with environmental affairs, social development, etc., and between the provinces across the boundaries between provinces will remain a function of the provinces after the NHI is implemented. And then, of course, the provision of technical and logistical support to district health councils and coordinating the health and medical services during provincial disasters, because it's the provinces that have other legislation that allow for that intersectoral management. Provinces will remain responsible for coordination of emergency medical services, as I said, but also forensic pathology, forensic clinical medicine, and the related services in the provision of the medical legal mortuaries and the medical legal health services. Provinces will provide and maintain equipment, vehicles, and healthcare facilities and consult with communities regarding health matters. That's how you maintain the stewardship. And obviously, overall, we need everybody to be involved in health and healthy lifestyles. The provinces are best placed to coordinate that. Also to provide environmental pollution control services, and then to conduct health systems research into programs, public health and health services generally. So I hope that's been just an overview of what's in the bill, and we look forward to answering questions. Thank you very much, Chair.
Thank you very much, Dr. Chris. DM, is there any other, or the DG, anything that you want to add?
No, thank you very much, Chairperson. We will await some clarity-seeking questions from the members, and then maybe we can come back with the team led by the DG. Thank you very much, Chairperson. Thank
you, Deputy Minister. Members, that was the presentation from the department. I will now ask any member for any clarity-seeking questions Just remember, members, this is not the official bill that has been coming to us from the portfolio committee because they're still busy. So we will have another bite when the official document will be handed over to us from the portfolio committee and the department and the minister. But if there's any clarity seeking questions that you would like to raise, you can now raise your hands and I will give you an opportunity. I see Member Christians.
Thank you very much, Chairperson. Is it okay if I leave my video off? We're just having bandwidth constraints in the Northern Cape.
It's fine, Member.
Chairperson, I just have a few questions of clarity. I heard that Dr. Chris said that the funding will come from appropriations. Now, obviously, I just have a few questions of clarity where that is concerned. So, with all the, after education has taken their bite, after NSFAS has taken their bite, how much will really be left to give to such a huge project as the NHI bill, if it is only taken from appropriations? And a big question for me is, will people be taxed personally? In other words, will the working class be taxed on their salary for this health bill? I just think I just need clarity on that. And then, of course, the constraints that hinder us currently include doctors and nurses currently that are placed late, doctors that cannot complete their crucial 2 years to complete their training. How will this bill circumvent that? How will this bill see to it that doctors and nurses don't leave the country in droves, and that our students actually complete their courses? Many of them are sitting at home currently. So we have a huge vacancy rate in South Africa for medical personnel. And will the NHI bill speak to that? And if so, how is it going to address that shortcoming? And then with regard to poor maintenance of health infrastructure, another huge issue, that's why our health system is in the fix it is. It's basically our infrastructure, management, just basic principles that are just not being adhered to. And I hear what Dr. Crisp has said about the centralization, but again, won't that take away from provinces who are doing well currently with maintaining infrastructure and general upkeep and just running their medical health facilities in the correct way? Primary health care, for example, clinics, how will the NHI see to it that there's not a decline in that? And more concerning for me is that in the bill, it seems to me that there's no real leeway for people who want second and third opinions. For example, if I go to the hospital and I have a concern and doctors brush me off, right? A few tests are done and they don't find anything. But I don't have the option of going for a second opinion or third opinion. There is a definite lack in this bill for second and third opinions. I just have a few more. And then, does this bill remove the choice of South Africans to choose their specific healthcare? Just a simple answer. In other words, if I am living in the Northern Cape and my healthcare facility is the Robert Mangaliso Sobukwe Hospital that is currently falling apart, there's a lack of doctors and nurses, etc., will that be my only avenue to get my healthcare seen to at that specific hospital? So in other words, will my choice of healthcare be removed? And then I just need clarity on the composition of the investigation unit. Maybe just a little bit more in depth. What will that investigation unit do? Yes, and I think my main question is just the personal income tax burden. What kind of burden will that put on the ordinary citizen, the ordinary working middle class, lower class citizen in our country who is already battling with regard to the very basics? Thank you, Chairperson.
Thank you, Member Christians. I don't see any other hands. Is there any other member who would like to see clarity?
Chairperson?
Yes, Member Chube.
My apologies, Chairperson. I'm struggling with the network where I am. May I proceed with the input that I want to make, Chair?
You may.
Okay, thank you very much, Chairperson. Mine is not of a question or clarity seeking, Chair, but I just wanted to make an input since we're dealing with the Department of Health, Chair. On the I think on the summary, and on the paragraph 3, there's a sentence there where it says there's a dissatisfaction with the accessibility and the quality of public health care. So, Chair, I just want to bring to the attention of the committee and the department that some of us, Chair, stays in the rural areas called Botshabelo, whereby the sections, the 4 sections, the section S, W, and V, and U, they're sharing one clinic, Chair. I know that this matter that I'm raising, I think it was raised in the NA last week. Now, Chair, what is happening is that you have 4 sections in a community that are sharing a one small clinic. And the hospital is, I think it's a bit far. I think it's 20 km from where we are staying. So I think, Chair, because I know this thing was raised and it was rejected in the NA, that clinics must not open 24 hours. I just want to bring to the attention of the committee and the department, Chair, that really, our people are really struggling. You can just imagine when 4, because there's a newly establishment now, 5 sections that are sharing one particular clinic. If that clinic's close at 6 o'clock, you might just think what would happen, Chair. Because, like I'm saying, that the hospital, I think it's 20 km from where we're staying. Even if you can call an ambulance late at night when when you have a problem or you're having a patient, I think there's a lack of ambulances in Botshabelo District Hospital, Chair. So at times they even take 3 hours to 4. At times they don't even come at all. They would tell us tomorrow to say that no, but there were no ambulances available. I think at the moment they were running with 3, if not 4 ambulances, Chairperson. I just wanted to bring this matter to the attention of the committee and the department, Chair, that maybe they may reconsider, Chair, opening clinics over time, like 24 hours, 7 days a week, because most of our people are unemployed. They're not working for them to be able to travel to the hospital that is far from where we're staying, Chair. So that's a concern that I wanted to bring to the attention of the committee, Chairperson. Thank you very much.
Thank you, Member Nchube. Is there another one? Members, I don't see any hands. Is there anyone for the last time? Member Leahy, do you want to speak?
Yeah, thank you, Chair. Ke batla go support-a kgang ya ga member Ntshube ya di tleliniki gore di bule 24 hours. Tota yone e utlwisa botlhoko. Maloba go na le mongwe o na tlhabilwe 16 holes ko Kgakala location. Ga founela ambulance go sokotswe. So gore a ye tleliniking ko toropong ke matsapa hana transport. Ha kra transport e mo charger more than 100 rand gana madi. So ke support-a ga member Ntshube gore ditleliniki di bule 24 hours. Yone e utlwisa botlhoko le nnete. Ke a leboga Chips.
Thank you, Member Lahili. Member Latuli.
Thank you, Chairperson, and greetings to everyone. I think the issue that the previous members are raising of clinics is a very concerning one. More especially us who stays in rural areas. I will speak of my area in Ndwedwe, where our clinic is Ndwedwe Clinic, and it's in Ward 15, but it services like 10 wards. I'm talking about Ward 12, Ward 18, Ward 14, Ward 15, 16, and 17. All those wards have to go to the clinic. And even the times that people wait in clinics is too long, not because the nurses and the doctors are not doing their jobs, but the community that they are servicing is too much. And also the issue of ambulances. I lost my brother 2 weeks ago, where he was hit by a car, and we had to wait for an ambulance, and then decided to take him to the clinic because we could see that now he was losing his life while we were waiting for an ambulance. So it's really a concerning issue, especially in rural areas, and you find that other areas ambulances can't go because in the roads, there's no access to go and pick up those who are sick. So I think we need to really zoom in on the issue of clinics and ambulances. Thank you, Chair.
Thank you, Member Latuli. I don't see any other hands. And then with that, questions in front of us, I will hand back to the Minister, the DG, and the department. Over to you, Minister.
No, thank you very much, Honorable Chair, and the members for those questions. DG has actually indicated that these questions will be better answered by our presenter, Dr. Nicholas Crisp, supported by Dr. Tulare Aquina. Let me just start, and then they will also refine my input, and then they will come one after the other. To actually address what Honorable Ntshube and Honorable Lehihi are saying, the private members' bill in the National Assembly was not thrown out because it had no substance. If you really listen to other members who were in support of the bill. However, the bill actually was not really having any financial assessment done on it as to how this will actually impact. If we were to say this bill implement tomorrow and you don't have any financial assessment report, then you would have been found wanting. Number two, it is also a desire and a plan of the Department of Health to continuously improve and open up more facilities 24 hours because of other comments that the honorable members have actually made here. And also what is but strong on this is to say part of this NHI program going forward will impact on the National Health Act. And among other things, this will also probably impact on the accessibility and the availability of services. One wants us to give our condolence to Honorable Lutuli for the loss of her brother through that process of a car accident. This impacts, again, among other things, on Honorable Lutuli, that there are certain specific ambulances that will not go. It's only those of the public sector that will go to Ndwedwe and to Bumbulu, but others choose not to go there because of the wear and tear fastness. So that is a process that must then be worked around to say, ambulance services in the country must not be providing for public or private, must be providing for citizens. Emergency care is for all of us. So that also might be addressed as we also improve and increase the number of facilities that are available on this. Honorable Christians, why would you probably, if your hospital, your clinic is not actually assisting you, are you able to jump and go to the next? The NHI is envisaging that, and through this process of Office of the Health Standard of Compliance, that a facility in Kimberley or in Da'a or anywhere in Kokstad will have to go through the accreditation process and be able to say this now meets this basic understanding that it will then go into that process. So there is that process that is on, and maybe the members who are logged in here will be able to give you the actual figures of where we are with certain clinics that have achieved what we call is an ideal clinic status vis-a-vis those that are still struggling, security at the gate, the fencing of the clinic, the availability of adequate staff, the records availability. All those are issues that are criteria that we are looking to. So there is that incremental assessment and supporting all our facilities to really be at the ideal level that actually is looked into. So that also goes into poor maintenance, to say, I'm not sure, we are actually, probably as I close the members, there is this document, which I'm not sure whether it will be visible. This document that you can be familiar with, all of us honorable members, it is an outcome of a meeting called by the president in 2018, and this document is called the Presidential Health Compact 2019. This document seems to say, the president is saying South Africans are complaining about poor staffing, infrastructure, attitude of staff, and the whole host of the things. Department of Health, do you have a plan? What can you do to put a plan that will make South Africans actually be able to say they see a change and improvement? So this plan is like our working document that we always continuously assess ourselves as a department. How far are we from achieving these things that we agreed collectively, both private and public, all stakeholders in the country participated and contributed to this document. So it's a working document that we will say one day, once these actually have been achieved, we will almost be at the level where we could be comfortable saying we're doing well. But it's a task of both public and the private healthcare sector. Maybe let me then allow our two leaders, Dr. Tulare, Dr. Crisp, who has been designated by the DG to assist us in clarity seeking of these other questions. Thank you very much, Chair.
Thanks very much, DM. Maybe let me have a first go at that. Thanks, Chair. So I think that health systems are complicated, and you don't fix them just by implementing or changing a piece of law. But what we do have at the moment is such a complicated and inequitable design in our system that what we are aiming to achieve is a far more efficient system. Now, what I mean by that is, at the moment, for example, we have 9 provincial departments who duplicate quite a lot of what they do. And between the provinces, because of the way the budgets are allocated, the transfer and the movement of patients across the boundaries between provinces for various services often ends up having duplicates of tests, duplicates of medicines, and so forth. It's inefficient. In the private sector, we have 76 medical schemes, and each of them has got an administration with trustees and so forth. And the administration costs on a very complicated system like that is very high. So the estimates are at least 15% of everything that medical scheme members pay is consumed in just purely administration. So part of what needs to happen is, one, we need equity. We need to redistribute what we have at the moment, the 8.5% of the GDP that we spend. And the question is, does this bill do that? Well, it will not do it overnight, but it will do it over time. And that's really what we have to concentrate on. So the questions from the Honourable Christians around the funding and appropriations. So this year, together with the appropriations that go to the provinces through the provincial equitable shares, together with the conditional grants, that is over 290 billion rand that we are already paying in tax and already Parliament is already appropriating for us one way or another and channeling into the public health system. Then there are tax credits, 34 billion rands worth of tax credits. There's also money going through the road accident fund, billions of rand going through the road accident fund, and so forth. So the fact of the matter is there's a lot of money already in the system. And really the starting point is how do we use it more efficiently and how do we access the many resources that are available in the country, but that are locked up and not accessible to everybody. Will we need to have additional taxes? Well, in time, when we take away, when the bill says that the benefits are provided, and that's what we were discussing earlier with Section 33, when the fund is paying for all the benefits that we need, then the fund will no longer, the law will no longer allow medical schemes to pay for and provide those benefits. But at that point, instead of paying for a medical aid, we will pay that money into the fund. And the way to do it in our law is through tax. So there are ways to structure that. And that's a discussion that you will still have in Parliament, I'm sure, but we have with Treasury and others. There are ways to do it. One is through increase of VAT. We don't like that because it's not pro-poor in any way. You can change general taxation or you can have a payroll tax. So for people, I'll use me as an example, who pays a medical scheme for a hospital plan at the moment, once I know the NHI is going to pay for the care that I would normally get through that process, then I can stop paying my medical scheme and pay the equivalent amounts in tax. Now that does not happen overnight. It does not have to be written in the Act, but it does need to be brought in slowly over time in regulations. So will we pay more taxes? For those of us who are wealthy, we probably will. But will we pay more than we pay now collectively for our healthcare? Highly unlikely. Usually the change is that you get rid of inefficiencies and you end up paying less. That is for us to manage over the coming years together. Honourable Christians also asked about how do we keep doctors and doctors being graduating and not being accommodated in the system. You are quite right, and we are anxious about that ourselves. What has happened is that over the years, we have put in motion a number of programs that increase the number of graduates available for absorption into the system. Now, that takes time, of course, because doctors study for 6 years and most other health professionals study for 4 years at least. Specialists study for way more than the 6 years. So as those improved systems and projects start to bear fruit, we have more graduates. And the problem that we have experienced is that they have all started to bear fruit at a time when the economy has tightened and the budgets that are allocated to the departments, either through provincial equitable shares or through conditional grants, are less than we have to absorb all of those personnel. Fortunately, we have got a bit of a reprieve for this year, next year, and the year after, where we were given an additional appropriation to manage through this period where there are lots of additional graduates. So we should not see the same problem we saw last year happening at the end of this year. We don't want professionals to leave the country. We think we need them all in the country, and we will do what we can to keep them in the country. But what we do want professionals to do is to be doing what they are trained to do and not have to be trying to find work from, by doing things that are potentially unnecessary or doing work of other cadres of personnel who could be doing that, who are paid less than the highly specialized people. Again, that's not something that happens at the drop of a hat. It's a process of managing. And having vacancies is one thing, but we don't have the budget to pay for the vacancies. That's the problem. And as we have more and more people becoming dependent on the public service, as people lose their jobs and the environment becomes more difficult in the economy, that's the challenge. We don't have an increasing health budget. We have a decreasing health budget. That has also affected the maintenance of facilities. So I can only agree with the Honourable Christians that is an area that concerns us and that we are working with all the provinces on to try and fix. The question of the primary healthcare clinics, I think the Honourable Deputy Minister has addressed. The Ideal Clinic program is improving the quality of what we have, but it's also through some of the conditional grants that we've had for a number of years now. We are getting additional clinics into spaces where there's high demand, and where Honourable Sube and Lehehe mentioned about specific clinics, and I think Honourable Lutuli as well. We are aware of the deficiencies in many communities, especially where those communities are growing. And there are plans over time to increase the numbers of clinics as well as the quality of the clinics. Again, that's not something you fix with the National Health Insurance Bill or Act, but it's what you fix with the programs of the funding that's available for capital works. There was a specific question about leeway for second and third opinions. Even in the public sector now, people do get second and third opinions. So there's no reason why that cannot be designed into the systems. The intention of national health insurance is not to straitjacket people. The intention is to get good, proper healthcare to everybody, but not to victimize people because they're poor, which is what happens in the system and the way we have it at the moment. And will we remove choice in the bill? The bill makes no reference to removing of choice. The bill doesn't go anywhere near that. It's the way we design our regulations that says once you have seen in the primary healthcare space and you get referred somewhere, where do you get referred? Well, you get referred to an accredited facility, which has the staff, which has the skill, which has the tools to do the job. So we need to build over this period sufficient accredited facilities that have the capabilities, and they will be both public and private accredited facilities. So in some places, the hospital that's nearest may not have, for argument's sake, cardiology services, and it may be that the primary healthcare physicians through the district hospital have to refer a person quite far to get to a specialized cardiac facility. And over time, one likes to fill those gaps once you work out where the concentration of the diseases are, and that's why that epidemiological profile I was referring to earlier is provided for in the bill. So there's no intention anywhere to remove choice, and there's no intention anywhere to prevent second and third opinions, and doctors do it all the time, asking one another, and patients can ask their doctors for opinions. Honourable Christians also asked about the investigating unit. So the provision in the bill is that public will, from time to time, complain. It happens in all systems. We want the National Health Insurance to investigate those complaints. It does not take away from the functions of the health ombuds or the functions of the public protector or the functions, if it's a money-related issue, of the SIU or anybody else. But in the first instance, the responsible organization for looking after the services that are paid for from the fund is the fund. So it needs a unit that investigates when there are complaints. The actual details of how it works, standard operating procedure, will be left to regulations. One doesn't want to tighten that so tight in the bill that when it's an act, you don't have room to move. So, yeah, I think I must stop at that point. Thank you, Honourable Chair at DM, but perhaps Dr. Tulare has comments that I haven't addressed. Thank you.
Thank you, Honourable Chair. I think Dr. Crisp has responded to most of the questions. There's just one question that I wanted to emphasize that was asked by Honourable Member Christians on infrastructure. and raising concerns that will be taking away from provinces who are doing well. And I just wanted to reflect that, in the slides and in the amendments to the National Health Act, what we are saying there is that infrastructure maintenance will still remain the function of provinces. It's only the services that are offered that are going to be redelegated back to the facilities that are going to be delivering the services. I also just want to highlight that in terms of central hospitals, the National Health Act in its current form already designates central hospitals to the national sphere. So it is not something new that we are bringing up. It's already there in law. It is just that for the purpose of NHI, it is important that this function of moving central hospitals to the national sphere is emphasized, specifically because we want those central hospitals to benefit the entire country as platforms for delivering of services, platforms for research, and platforms for training. So they should be accessible to the rest of the country and not just confined to one province. But the provisions are already in existence in the National Health Act. So that is all that I wanted to emphasize, Honorable Chair. I think Dr. Crisp and Honorable Deputy Minister have responded to the rest of the questions. Thank you.
Thank you, Minister. Is there, so you're, sorry, from the department side, you are finished now.
Yes, Honorable Chairperson, we are finished with our contributions to the responses. Thanks.
Thank you then. Members, let me take the opportunity to thank the Deputy Minister, DG, and the rest of the delegation of the Department of Health for that brief discussions that we were able to have, also for the presentation. I think DM, it gives this committee also an insight of what to expect when the bill will actually come to us. I really need to thank you for coming to our meeting this morning. Members, is there any other issue that any member would like to seek a clarity on before I excuse the Minister and the department? I don't see any hands.
Sure.
Yes, Member Chabaleng.
Sorry, I got cut out of the meeting for quite a long time, and I don't want to take the committee back. They're just general worries about the decline in the budget all the time, and that given that, how are we going to achieve this? I'm sure this was answered in the questions that were asked earlier, because it's a very important issue that has given us a headache over some time. The other will be that I hope this is the first briefing that we're having. I hope is the beginning of many other engagements to come. And as we engage, we'll be zeroing in on issues that are very central to the well-being of the fund itself, and the idea and the ideals behind the national health insurance. Thanks, Chairperson. I'm sorry I got cut out of the meeting, but I hope we'll still have enough time to engage in the future. Yes. Thank you.
Mr. Chabaleng. That questions and the budget was explained. There was questions raised by member Christians, and I think it was fully covered. We know Member Chabaleng is sitting in Limpopo, in a very remote area, DM, and he's experiencing problems every time. But just to give you assurance, Member Chabaling, that has been covered by the department. Thank you. And then without any further ado, TM, we like to wish you well, give our regards to the Minister, and then we will excuse you and your department so that we can continue with our in-house discussions. Thank you.
Thank you very much, Honorable Chair. We will convey your warm greetings to the Minister, and we will now exit the platform. Thank you very much. Have a good day to you and all the members too.
Sorry, I'm muted. Thanks, Marcel. We've got some minutes to approve, members. The minutes has been sent to all of us. So I won't go through reading minutes page by page. So the minutes for the 24th of May is in front of us, and the agenda was a briefing by the Department of Women, Youth and Persons with Disabilities on the annual performance plan and the budget 2022-2023. So I will ask members, if you went through the minutes, did you find any corrections that you need to make in the minutes? Member Chabaling, is that an old hand? Okay. So, members, if you did not have any corrections, can I ask for a mover and a second for the adoption of the set of minutes?
Move, Chair.
Okay, so I've got Member Dongeni and Member Chabaling. Thank you, members. The next one, Marcel. Okay, the next set of minutes, members, is the 31st of May. Something went wrong here, Marcel. Can we have the minutes shaped again? Okay, the minutes is the minutes of the 31st of May 2022. And it was the adoption of the budget vote reports 16, 17, 18, and 19. If there's a member who wants to make any corrections, you may do so. If there's no corrections, can I have a mover and a seconder, please? Can I have a mover and a seconder, please, for the adoption of the minutes?
Dongeni, Chair.
Thank you, Member Dongeni. Is there a seconder? Thank you, Member Leahy. Marcel, you can put the other one up. Sorry, I was muted, members. The report of the Select Committee on Health and Social Services and the annual performance plan budget for 20 of the Department of Women, Youth and Persons with Disabilities for the financial year 22-23 dated 7 June 2022. Members, did you find any corrections on this report? If there's no corrections, can I have a mover and a seconder for the adoption of this report, please?
Member Leahy.
Thank you, Member Leahy. Seconder.
Chabele.
Thank you, Member Chabale. Is there another one, Marcel?
Chairperson, no, we are done. That was it.
Thank you, Marcel. Is there any other discussions, documents, or something that we need to do?
Yeah, Chairperson, I just wanted to ask if it's okay with you.
Yes.
It's about the Korean trip. What are outstanding information? Has everybody presented what they're supposed to give? If not so, by when should they have done that?
Thank you, Member Chamberlain. Marcel, can you give an update?
Thank you, Chairperson. Good morning, members, once again, and colleagues. Just to give you a quick update where we are in the process, we have written to our embassy via our embassy and co-chairperson to the South Koreans. They have just elected a new government, so they are trying to work with our program. We haven't received any confirmation of our dates as yet because of the current situation. In terms of the legwork on our side, we have now finished our political application. We are hoping to submit by the end of this week, Chair. In terms of members that have responded, all members have responded in terms of the documentation required. I think there's one or two members that I still need to talk to. If Ms. Ntsubi can please give me a call. Other than that, members, I will keep you updated as to visa requirements as well as COVID regulations. But like I'm saying, we are waiting on confirmation from Seoul before we can proceed and confirm our dates. Thank you, Chair.
Thank you, Marcel. There you've got it, members. Please make contact with Marcel on your outstanding issues. Then from my side, I need to thank all members who signed in this morning. Also from our support staff, thank you very much.
Just a Chairperson, that members, if members haven't sent their things, they should not expect Marcel to be chasing them around. Marcel has done her job. We're in this meeting. Anyone who's got outstanding information gets reported in these meetings. And yeah, I don't think it's a duty to follow us around. Those who are willing to be part of this will present their things on time.
Thank you for that.
Thank you. Yeah.
Thank you to the support staff for this morning's meeting. I think it was a very, very useful presentation that we received. It will also give us a better insight on the bill, and when the bill comes eventually officially to us, we already had an insight of the bill. But then without any ado, members, I want to close this meeting. This meeting is officially adjourned. Thank you.
Baie dankie, voorsitter.
Bye.
Everyone, thank you.
Thank you, Chair.
Record.